Clinical decision-making in stroke, emphasis on the upper extremity. Our objectives for today's lesson are to discuss common impairments seen in the upper extremity following stroke, relate these impairments to goal setting and prognosis for arm recovery, and discuss treatment options for arm recovery. Functional goal setting for the upper extremity is extremely important following a stroke. The upper extremities are involved in a number of functional tasks, including object transport and manipulation, our ability to pick up and move objects. That involves proximal control from the shoulder muscles and scapula, as well as distal control from the hand and fingers. Distal control is important for grasping objects as well as releasing objects when you would like to. The upper extremity is also involved in active assist, including bimanual tasks like opening a jar, and stabilizing assist, or weight bearing through the upper extremity, like if we're needing to assist with balance or help to get out of a chair. The three most common areas affected from stroke are the middle cerebral artery, the anterior cerebral artery, and the posterior cerebral artery. Specifically, the MCA, which is designated in red, is the most commonly occluded artery in stroke and results in a loss of arm function more than a loss of leg function. This is because arm function is largely supported by the territory that's governed by the middle cerebral artery. The common impairments impacting upper extremity recovery post-stroke include motor impairments such as weakness, loss of isolated joint control, and abnormal muscle tone like spasticity or flaccidity, a loss of range of motion, and sensory changes or sensory loss. Weakness or hemiparesis contributes to most of the loss of function in both acute and chronic stroke. The loss of upper extremity function results from weakness across all of the joints. What I want you to take away from these pictures is that at basically any time post-stroke, whether you're 1 month or 3 months, the severity of your weakness explains how much function you're going to ultimately have. Said another way, if you can't move very much of your arm, then it's unlikely your upper extremity is going to be very functional. Proximal weakness or weakness in the shoulder limits our ability to move the arm against gravity. Particularly, we have decreased control into arm flexion, abduction, and external rotation. We also have decreased control from the scapula, which can result in possible shoulder subluxation or dislocation if the weakness is severe. Distal weakness or weakness in the wrist, hand, and fingers can cause an ineffective ability to grasp. We can either use too little force and not be able to hold very small, light objects, or too much force. We can also see a difficulty in releasing items. We can pick them up, but we can't put them down. Loss of isolated control describes our inability to move a single joint at a time independent of the other joints. For example, being able to flex your elbow without flexing your shoulder or your wrist. We'll most commonly see a flexion synergy or an extension synergy. The impact of this is that we have difficulty making skilled movements of the hand or the arm because we need isolated joint action. When we're incapable of moving, for example, our wrist without moving our elbow or shoulder, it may be difficult to do something like sign your name on a document. When weakness or poor upper extremity control are evident, we often use adaptive compensatory strategies in order to move the arm. Sometimes we'll see patients who use excessive trunk displacement or rotation, excessive scapular elevation, a shoulder shrug in order to elevate the arm, or internal rotation in order to pick up objects. The most impactful of these is learned non-use, where essentially our patients will stop using their hemiparetic limb altogether as they don't feel like they can accomplish any functional tasks. Prognosis for upper extremity functional recovery. There are a number of factors at the onset of stroke, such as strength or range of motion ratings, or within the first 30 days that can indicate how much a patient is likely to recover. We will now discuss some prognostic indicators for recovery of the upper extremity following stroke and what that means for different treatment options. A recent meta-analysis by Cooper et al. Studied the prediction of upper extremity recovery, looking at factors such as age, gender, lesion site, initial motor impairment or function, motor evoked potentials and somatosensory evoked potentials. The bottom line here is the initial severity of upper limb motor impairment or function, or the amount of strength that a person had at the onset of stroke, was found to be the most significant predictor of overall upper limb recovery. Specifically, active finger extension and active shoulder abduction at 48 hours post-stroke gives a 98% probability of achieving some degree of dexterity by the first 6 months. Further, 60% of individuals with active finger extension within 72 hours regained full recovery of function by the first 6 months. Other factors influencing functional arm recovery include the ability to make quick movements in motor impairments. That's a positive sign. If there are non-motor impairments such as sensory loss or visual field loss, there is less likelihood of returning to functional arm use. And most importantly, if there is no voluntary movement at 14 days or no measurable grip at 4 weeks, that's a fairly poor prognosis for upper extremity recovery. Again, recovery of upper extremity function post-stroke is largely dependent on the initial grade of weakness of the limb. It's also important to note that functional improvements will typically lag behind impairment-based changes. Just because someone's bicep strength objectively improves doesn't necessarily mean they can reach something from a tall shelf. Typically, those with mild to moderate paresis are especially sensitive to the types of interventions we choose for them, and they have the most potential for recovery. Muscle tone can also have an impact on upper extremity function. For example, low muscle tone at the shoulder may contribute to shoulder subluxation or eventual dislocation, or low muscle tone at the wrist and hand may cause a patient to injure their distal wrist, hand, or fingers. High muscle tone can serve as a deforming force, leading to tightness or contracture, as well as difficulty with personal hygiene. Loss of range of motion is also a factor. Some contributing factors to that are gravity, spasticity, weakness or flaccidity, and especially learned non-use. Loss of range of motion is most commonly seen at the shoulder into flexion, external rotation, and abduction, wrist and finger extension, or elbow extension. Following stroke, we use a number of different ways to measure how well somebody is doing. We can use performance-based measures, as listed below, self-report measures, where a patient indicates how well they feel like they're doing, or impairment-based measures. We will now move into discussion of different types of interventions for recovery of the upper extremity following stroke. There are 2 different strategies we typically use when approaching the upper extremity. There's a compensatory approach. This works for patients with severe paresis or weakness. Our main goals here are to minimize contractures, minimize edema, and promoting use of the upper extremity as an assist only, as their dexterity is going to be limited. For those with mild to moderate paresis or weakness, we use a recovery approach, and the goal there is to return the arm and hand to a reasonable level of dexterity and use. It's important to note that a recovery approach may not result in a 100% return to prior level of function, but should promote normal functional use of the hemiparetic extremity whenever possible. In the acute phase, within the first few weeks following stroke, there are a number of things we want to address with our patients, including range of motion exercises and positioning to maintain or improve mobility and function, teaching the patient and the caregiver proper handling skills in order to minimize pain, positioning of the hand to reduce edema, and discussion of upper extremity devices, whether or not we may want to use a sling, a walker, or a cane. This type of education in the acute phase is appropriate for all patients regardless of the severity of their weakness. In particular, discussion and education of preventing shoulder pain and possible subluxation can impact overall function and recovery. Shoulder pain following stroke is associated with a loss of motor function. We can also see reduced humeral external rotation, which can lead to increased rotator cuff compression, which increases with humeral elevation and can cause impingement and pain. We want to make sure to educate our patients and caregivers on how to position the arm appropriately to stretch the shoulder, particularly stretching the adductors and internal rotators. In supine, this can mean lying down with the hands behind the head, or we can position the patient sitting at a table with the shoulder in abduction and external rotation. We also want to encourage pain-free active exercise with emphasis on external rotation, abductors, and flexors. All of these devices here can offer arm support and some protection from harm and increased pain of the shoulder. Along with shoulder pain, weakness of the shoulder girdle muscles following stroke can often lead to a shoulder subluxation, most typically in the inferior direction. Low tone and the pull of gravity on the arm towards the ground can also contribute to subluxation. This ultimately results in stretching of the inactive soft tissue, particularly the ligaments in the glenohumeral joint. In order to test whether or not there's a subluxation, you can use the sulcus sign. To do that, you place traction on the humerus with the arm at the patient's side. If there's a gap greater than 1 centimeter between the humeral head and the undersurface of the acromion, it's considered positive and suggestive of an inferior instability. In order to prevent or to decrease the intensity of a shoulder subluxation, there are different handling skills that a patient, a physical therapist, or a caregiver can implement. Specifically, we're going to want to upwardly rotate the scapula or bring a humerus into neutral and then lift into the joint. If subluxation is continuing to occur, we can use a sling. Current evidence indicates that a sling isn't necessarily going to prevent shoulder subluxation, but it might diminish the feeling of a downward pull of the arm and decrease pain. There are a number of types of slings that we can use. We have a cuff sling here, which is mostly around the shoulder joint. And we have the Give More sling, which not only provides support to the shoulder joint, but provides a little bit of support and positioning to the hand. For a patient with mild to moderate paresis who you've determined would benefit most from a recovery intervention, we want to focus most on task-specific training and strengthening. There's strong evidence in the literature supporting interventions that include tasks that are specific and meaningful to the patient. This may mean asking a patient to tell you what types of things they'd like to work on. Some examples could be sweeping the floor, opening a book, throwing a ball, doing the dishes, or reaching for an object on a tall shelf. When you've decided which task you'd like to work on, you want to first analyze the patient's movements. Watch them perform the task and determine what movement components are missing. You can then structure your intervention based on those deficits. Let's take, for example, picking up an object and carrying it across a room. Think about what muscle strength you need and what range of motion you need to bend forward, pick up an object, hold it, and carry it across a room. We know that an initial position of scapular abduction and elevation correlates to a patient's ability to lift and carry an object. In Figure A, we have a patient who is in his standard resting position. In Figure B, we've added a rope and a rod in order to support the patient's scapula into a more functional position. With that rope and rod, we've now asked the patient to carry an object across the room with their scapula in proper positioning to perform the task. Multiple repetitions of this should improve this patient's ability to perform lifting and carrying an object without use of the rod. In the preceding example, the patient was performing a functional task using both his hemiparetic and his unaffected side, but there has been some debate in the literature as to whether functional training should focus on unilateral or bilateral arm use. In 2012, a systematic review and meta-analysis involving 452 patients looked at whether or not unilateral or bilateral arm use was effective. What they found was that a successful intervention likely depends on the amount of upper limb paresis and the timing of the intervention. With severe or moderate paresis, unilateral and bilateral arm training appear to be equally effective. However, with mild paresis, unilateral training of the weaker arm tends to be more successful. There are some key elements of task-specific arm and hand training from the research that should be pointed out. First of all, is overall postural control and stability should be addressed as the arm training is done. This is going to improve arm function. Essentially, if we're not able to hold our trunk upright or stabilize in the scapula, we're not going to be as successful in reaching outside of our base of support. So for example, in a reaching task, we want to have the patient look at and attend to the object they want to grasp, use their eyes, then their head, and then their hand to locate that object. We then want to induce different types of challenges or error using different object shapes, weights, and textures. Every object that we use requires a different motor control strategy, and we want to challenge as many strategies as possible. The ability to pick up a light coffee cup that is empty is much different than the ability to pick up a heavy coffee mug that is full of coffee, and further to bring it to your mouth to drink it. Circuit training is another way that we can use task-specific interventions in a group setting to improve function. In this setting, you can have a number of patients that are allocated to different stations. Each station used in this intervention may incorporate an upper extremity functional task. For example, you could have 5 different stations. In one station, they practice turning a doorknob, in another, throwing a ball, another, eating with a utensil, another, sweeping a floor, and for the last, walking while carrying an object. This type of training is appropriate for individuals with mild or moderate paresis, and it's important to remember that if you have many patients in a room with only one therapist, safety is a factor. But we do know that circuit training has been successful in helping patients improve overall function, as well as find a sense of community in other patients who have similar impairments. Another recovery strategy that can be used for patients with moderate hemiparesis is constraint-induced movement therapy, or CIMT. This is a technique designed to overcome learned non-use of a more involved upper extremity post-stroke. It involves intensive practice of the involved upper extremity while restricting use of the lesser involved limb. The lesser involved limb is physically restricted for a minimum of 6 hours a day and usually for 90% of waking hours. This also involves 2 consecutive weeks of practice and restriction of the lesser involved limb. Prior to beginning this type of treatment, the patient and the therapist agree on specific tasks that that patient is going to practice. So for example, one patient may want to work on handwriting while another might want to work on doing the dishes. The goal here is to force use and repetitive practice of functional tasks of the involved side. For CIMT, patient selection is very important. We know that this type of treatment only works for patients who meet very specific criteria. The inclusion criteria are adequate cognition, active wrist extension up to 20 degrees, and active MCP extension to 10 degrees. Just as important are the exclusion criteria, which are serious sensory deficits, severe aphasia, severe depression, or soft tissue injury to the involved limb. It's also important to note that there's strong evidence that this type of treatment can create change even in individuals with chronic stroke, more than 6 months post-onset. There's also a modified CIMT protocol that can be used. It involves the same principles as CIMT, which are restraining of the less affected upper extremity and practice of functional activities, but it involves a reduced intensity, duration, and frequency. An example of this would be task practice 2 hours a day, 5 days a week, and 3 weeks total, as opposed to 6 hours a day for 2 full weeks. Restraint of the lesser involved limb, or restraint for the lesser involved limb for 5 days a week or 5 hours a day. In general, modified CIMT is thought to be more effective than control therapies for improving arm motor function, meaning that using a modified CIMT, if that's easier or better for the patient, is still better than an unstructured or uncoordinated physical therapy effort. There were 3 main learning objectives that we wanted to address in today's lecture. The first was to discuss common impairments seen in the upper extremity following stroke. We discussed shoulder pain, subluxation, hemiparesis, and flaccidity. We then wanted to relate those impairments to goal setting and prognosis for arm recovery. We did this by discussing both compensatory and recovery strategies following stroke and what types of patients would fall into those categories. And finally, we wanted to discuss different treatment options for arm recovery. This included a discussion of task-specific training, circuit training, constraint-induced movement therapy, and strengthening. I hope that you all were able to get some good treatment ideas and a better understanding of upper extremity impairments following stroke. Thank you very much for your time.